Welcome again. So in the next minutes, Georg Schett and me, we would like to introduce to you our program on CAR T cells in non-malignant disease, and we are focused on B-cell mediated autoimmune disease. So here are my disclosures. So CD19 CAR T cells have emerged as a powerful tool for the treatment of relapsed and refractory B-cell malignancies, as we have heard. And so far we have 4 CD19 approved products for lymphoma, and they are all some similarities. So the antibody fragment is the same, but as we have heard, they are different co-stimulatory domains, and also the production of the cells is different. This is very important when we talk about CAR T cells, that each product is a little bit different. We and others have asked the question whether there is a role of CAR T cells beyond cancer. And as you have heard already, we have decided to focus on so-called B-cell mediated autoimmune disease. And if you consider such an approach, there are in principle different options. One is to target the auto-antigen specific B cells, and this is something we will hear later by Dr. Payne, focusing on that. And the other option is to really target the whole B cell repertoire, so depleting all B cells, such as CAR T cells directed against CD19. So when you consider such an approach to target autoreactive B cells, we should first of all recapitulate the surface antigen expression of the B cell lineage. And this is shown here. And you can see that CD19 is broadly expressed from pro-B cells up to plasmablasts, but it's not expressed on long-lived plasma cells. If you really want to target long-lived plasma cells, other antigens such as BCMA or CD38 are the right antigens. So we thought that as systemic lupus erythematosus is a wonderful disease model for such an approach using CD19 CAR T cells. Why? So SLE is a severe autoimmune disease, as you know, characterized by the formation of autoantibodies and immune-mediated inflammation and organ damage. While autoreactive B cells play a key role in the pathogenesis of this disease, B-cell depletion by antibodies, such as rituximab, has only limited efficacy. And this paradox has been attributed to the persistence of autoreactive B cells in the organs and inflamed tissues. So we hypothesized that CAR T cells may be more potently depleting target cells than monoclonal antibodies due to a better tissue penetration. And our hypothesis is based on preclinical data showing that CD19 CAR T cells were capable of reversing SLE manifestations in 2 mouse models. One of these mouse models will be presented later by Dr. Radic, so I will not go into detail using the preclinical data. CAR T cell, as we have already heard, CAR T cell therapy is so far a very complex approach, starting from apheresis up to expansion of the cells and transfection with the CAR, and then expansion again, and quality control, and then the reinfusion of the cells. When you consider an approach for autoimmune disease, there are some different challenges coming up. First of all, the patients are lymphopenic. They have received immunosuppressive treatments like steroids and other immunosuppressive drugs for years. So the question is it possible to induce CAR T cells out of such a patient from these heavily pretreated patients? The other challenge might be that if you produce such CAR T cells, there's a risk of also activating autoreactive T cells. So that is something that was one of my major concerns when we started, that we maybe do worse because we activate these autoreactive T cells. Furthermore, of course, the organ damage, when you go for the clinical, for the toxicity problems, most of the patients have organ damage like lung, kidney, and other organs. So the question is, when the patient has cytokine release syndrome and other toxicities, whether there's a higher risk for these patients compared to cancer patients. So coming to the production, we are in the privileged situation that we can have the chance of a point-of-care production of CAR T cells in my department. The product that we manufactured was used using the automated clinic pathology system, and we have a manufacturing license for different CAR T-cell products. And what is also an advantage is that our GMP facility is directly located at our CAR T-cell unit. So here I have summarized our approach. So for our studies we will present now, we use the second generation lentiviral vector encoding in an anti-CD19 CAR T that was kindly provided by Miltenyi Biotech. And after conditioning with cyclophosphamide and fludarabine, that was a dose we have also used in a phase 1 trial in malignant lymphoma. The patients received 1 million CD19 CAR T cells per kilogram body weight as a single infusion. And what is very important that we have also the clinical data from the same dose and the same fludarabine and cyclophosphamide dose from lymphomatization, where we can nicely now compare the data from the patient with malignant disease and the patient with autoimmune disease. What I also would like to emphasize here is that our product is a fresh in, fresh out product. That means we never freeze these cells. That may have an advantage regarding the quality of the T cells. So in the next minutes, Georg will then present the clinical data of our first 15 patients we have treated so far. It was a longer follow-up, and the patients we will present most of them have SLE, but we will also show you data from patient with systemic sclerosis and patient with idiopathic inflammatory myositis, which is immune-mediated disease that primarily affects the skeletal muscles, but can also involve organs such as lungs, skin, and joints. So here's the patient characteristics. So 15 patients, 8 of them had SLE, 3 with myositis, and 4 with SSC. And you can see that the patients are very young, a median age of 36 years, with a median duration of 4 years, disease duration, and all of them have received previous treatments with a mean of 5 treatments before. The median follow-up for this project is 15 months, and all of them had autoantibodies present, and here you can see also the summary of the organ involvement. So you can see that all these patients are heavily pretreated with active progressive disease at time of indication. So the first slide, the next slide I will show you and answer the question, is it possible to successfully generate these CAR T cells? And the answer is yes. We could expand these CAR T cells with a transduction efficiency between 20 to 40%, and had no problem with out of specification product. So the answer is yes. Although these patients are heavily pretreatment, we can nicely expand them, and the CD4 CD8 ratio is quite similar to that what we see also in tumor patients. So now the question is, what happens if we transfer these cells to the patient? Can we detect them, and do they expand? And this is shown here. So on the upper you see the B cell depletion. So this is CD19 against SSC, and you see before lymphodepletion 1.8% B cells, and starting from day 4 you see this deep depletion of B cells. And here you can see the expansion of CAR T cells, so CD3 against CAR, and you can see starting from day 4 up to day 9, you see up to, in this patient, 41% of the T cells express the CAR. You see this nice expansion, and then there is a drop of the cells with 3% at day 60. On this slide, you see the summary of the 15 patients. So this is on the left side the CAR T cell expansion, and you see there's a quite homogeneous repertoire. So most of them have a peak at day 9, and then the cells are going down. And on the right side, you can see the B cell depletion, also very homogeneous, and you see this complete and sustained depletion of circulating B cells. And before Georg is now starting to present the clinical data and the B cell data, I would just show you one example of a patient, of 2 patients, one with lymphoma and one with autoimmune disease, that received the same product, so the same CAR, the same cell dose, and also the same lymphodepletion. And it's a little bit not nicely seen, but what I would like to show you is that here in this patient, starting from day 58, we could not detect any CAR T cells anymore. And with the same procedure, a patient with lymphoma, as Fabian has already showed you, here on day 860, so more than 2 years, we can still detect the CAR T cells in this patient. So this is one of the major differences, and this is something we will, I think, discuss later, the difference between patient with malignant disease and autoimmune disease, this persistent, long-term persistence in patient with lymphoma, and not long-term persistence in patient with autoimmune disease. And the question is, why is this the case? But before we discuss that, I would like to ask Georg now to present the clinical data and also the very fascinating data on the B-cell repertoire. Georg.
Okay, so thank you, Andreas. And I want to give you a short overview what happened with the first patient we treated with CAR T cells in our facility. And it was actually in the middle of the corona pandemics in March 2021, when we had this young lady in front of us, and she cycled through many drugs, including quite heavy drugs like cyclophosphamide, and also was B-cell depleted by rituximab. But despite that, she had a very severe lupus involving the heart, the lungs, and the kidneys. And her disease activity, you can see that she has very severe proteinuria with 4 gram protein per day, and very high double-stranded DNA antibodies. And since she received everything, and she had really a poor prognosis by means of that situation, we decided actually in an interdisciplinary conference that she would be eligible for CAR T-cell therapy. Dimitrios, Andreas, and also Gerhard Krönke, who is now in Berlin, and myself are behind the patient, and we made this decision was not an easy one. Yeah? We feared actually that she might actually suffer from a severe cytokine storm, but it didn't happen. This didn't happen. Instead, she had a remarkable resolution of lupus, and you can see that here illustrated by the fact that there is a flat line with the B cell. So this red line is the CAR T cell infusion, and you can see B cells are gone. This is the first time the patient had no B cells, despite rituximab pre-exposure. She had her double-strand DNA antibodies plummeted, which was very remarkable because we never thought that the patient would seroconvert. The C3 levels, marking immune complex deposits in the tissue, increased, so that means there's no consumption of C3, and her proteinuria went down. And that was really the initiation that this might really work. And I give you this picture, which was made in December 2023, 1,000 days the patient had been treated. And I should say that at the time of treatment, she stopped her glucocorticoids and she stopped all immunosuppressive drugs. And she's still off any drug therapy 3 years after her initial treatment. That's very remarkable because it was a very severe disease. And you can see what happened, zero disease activity. The anti-double-stranded DNA antibody were off. And what was very remarkable that first the CAR T cells, as Andreas said, show peak, but then zero CAR T cells. And the B cells came back after about 100 days and stayed. And that was also interesting because she didn't get the antibodies back, despite her B cells were recovering. And we were not sure if the B cells come back. That was very unclear. So now, bottom line, we have treated 15 patients. We have treated a little bit more than this now. But these 15 patients were, I think, a landmark group of patients with 3 different autoimmune diseases, 8 lupus, 3 myositis, and 4 scleroderma. And these patients are all off any immunosuppressive therapy, as you see here. And the lupus patients all met a very stringent endpoint, which is the so-called DORIS remission. The myositis patient all met a very stringent endpoint, which is the ACR major improvement. And also the scleroderma patients dramatically improved with respect to skin disease, but also in part to lung involvement. Now, what did we see? What is interesting here? First interesting part is that the B cells consistently come back. So we have not seen a single patient who had long-term B-cell aplasia. That might happen, we don't know, but at least it is probably not common. And you can see that here, this is 800 days. And you can see here this deep B-cell aplasia. And by the way, the lymph nodes are completely empty of B-cells. We do lymph node biopsies and there's not a single B-cell left. But from the bone marrow, they are reconstituted in all the cases, which is very reassuring because you don't want to have a long-term B-cell depleted patients. And what is also important that despite the B-cell repletion, you see actually that the disease activity in the 8 patients with lupus as an example, and the black arrowhead marked observation time up to 24 months is off, that's lupus activity, C3 is normal, and the double-stranded DNA zero converted, and the proteinuria is down. Now, what does it mean? What do we do here? What we think is that would be the time axis here, and that would be the depth of B-cell depletion. We think that we really deplete very, very deep for a short time, and then you replete. So in fact, B-cells in the periphery are earlier back than with rituximab or obinutuzumab treatment. And that means that probably what we do, we eradicate everything, expect a long-lived plasma cell, and then you build up a new naive B-cell system which does not have the autoimmunity anymore. So this we showed in an analysis of the B-cells coming back. And basically the B-cells coming back represent a baby B-cell system. So you can see here baseline, early reconstitution after 4 months, and late reconstitution, established reconstitution after 1 year. And you can see practically the vast majority of B cells are naive cells. And the memory pool is dramatically reduced. So there's a split axis here. And recovers a little bit after 1 year. So it's like the build-up of a memory pool in a child, with a slow increase of memory B cell. And what is also very remarkable that after 1 year, you don't see these activated plasmablasts anymore, and also the lupus-associated activated memory B cells, also known as double negative 2 cells or aged B cells. Then even more important, when you go deeper, you can see that the so-called arrangement of VJ chains is actually very heterogeneous, resembling actually like a healthy individual. You can see here, this is a so-called circus plot, and you can see the more lines are the heterogeneous, the white is the VJ arrangement. And you can see that that's very similar in the patients after the treatment. And also the most frequently expressed VJ genes that would represent the healthy individual, the solid line, is very much in line with the treated patients. So we think that these patients lack the clonality and build up a completely new B-cell system. And this is probably why we do see a seroconversion of the lupus-related antibodies. As you see here, double-stranded DNA at the upper left, but also you can see that other antibody species like SM antibodies, histone antibodies disappear after the treatment. So the second interesting aspect is that CD20, as you know, they do not tackle plasmablasts and plasma cells, but also CD19 is not tackling the plasma cell, but the plasmablast, which is probably good because the plasmablast seems to be the main autoantibody producing cell in this setting. Now, that the plasma cell is spared is quite important as the typical vaccination antibodies like anti-measles, mumps, rubella, tetanus, pneumococcus, and SARS-CoV-2 are not very much touched. There is some decline, but you can see that after the CAR T-cell treatment, they are still existent. Look at, for instance, the very stable tetanus antibody titer. What is also remarkable is that when you vaccinate, and this is indicated by the red arrowheads, so these were actually vaccinations which are done by the family physician, the patient respond. So when the B cells are back and you vaccinate, you can still get an adequate humoral response. The last interesting part is tolerability. So tolerability, we were fearing, of course, the cytokine release syndrome. And this is not obviously a bigger problem, because you can see here that there is cytokine release, but that's usually grade 1, which is an increase in body temperature between day 1 and day 4 after CAR T-cell therapy, and can be very well managed with antipyretics. Sometimes we need a single shot of tocilizumab to get rid of the fever, but you can also see that the blood pressure is not much changed, and there is no higher problem with hemodynamic instability and oxygen requirement. Why is that? We think it's because that the target engagement in cancer is much higher, with a higher burden of B cells in the body, as in autoimmunity with much lower B cell burden. So the level of CAR T cell engagement at once is much lower, and therefore we have less cytokine release. And this is the last slide, or the second last slide, and I just want to share with you some considerations and challenges for the future. I think the critical part is pre-procedural things: disease selection, patient selection. Is it really a B-cell dependent disease? Have you established outcomes to measure response? And is there not too much damage in a certain patient? Because if there is damage, you will not see, of course, an improvement. The others are related to procedural things, target selection. So some autoantibodies might be anchored more in the plasma cell compartment than in the plasmablast compartment. So they would profit actually from BCMA targeting, for instance. And how important is the lymphodepletion? So we were very conservative in our facility to give always the same lymphodepletion. We had occasional patients with half lymphodepletion, and it also worked. So it might be possible that you can reduce the lymphodepletion. Procedural events are also concomitant treatment. We think that we should be very careful with concomitant T-cell targeted drugs, especially in the B-cell aplasia phase. We have seen some patients receive that in other centers, but a combined B and T-cell ablation, I think, can be very critical for opportunistic infection. And treating toxicities, this is very well established nowadays, and it was actually not a big problem so far in our center. And then monitoring is interesting. You can monitor very well because you can see very nicely that the B cell go away and come back. And you can also monitor the CAR T cells very well. So you can see what actually the drug you give is doing. And finally, treating relapses is pretty interesting. We had one relapse so far, which we didn't have, which was a recent development. And in this case, we decided to do a re-exposure with existing CAR T cells, which is possible, and it's actually a simple approach, I would say. And, but when there is, of course, mild disease, you could think of glucocorticoids and other options to treat the disease. So at the end, I thank the patients. These are 2 patients. One is even here and will share with us her experience. And I also want to mention here at the end that this is an endeavor of an interdisciplinary team of hemato-oncology and rheumatology, and we really enjoyed this with Andreas over the last 3 years to do this together. So now it's open for discussion. Andreas, come on.